Folliculitis. Definition. Folliculitis is an inflammatory reaction in the hair follicle caused by bacteria, usually S. aureus. Clinically, the lesion appears as a pustule, often with a central hair. Folliculitis, pustule with centrally placed hair. Incidence. Folliculitis is relatively common. In the general healthy population, the annual incidence of symptomatic, clinically recognized folliculitis is likely 1 to 5 per 1,000 persons, but if including mild, self-resolving cases, it probably affects 10 to 20% of people at some point in life. History. Folliculitis is usually asymptomatic. Occasionally, patients complain of mild discomfort or pruritus associated with the lesions. The process may be chronic or recurrent. Physical examination. A pustule is the predominant lesion, although papules may be found. The lesions are individual and do not become confluent. They are usually distributed on the buttocks and thighs but may also occur in the beard area and sometimes on the scalp. The key to the diagnosis is appreciated only on close inspection, whereby hairs can be seen in the exact center of many of the lesions. Folliculitis, pustules and crusted papules on the buttocks of an infant that cultured positive for Staphylococcus aureus. Differential diagnosis. The distribution, absence of comedones, and presence of a hair growing from the pustules help to differentiate folliculitis from acne. Gram-negative organisms can cause gram-negative folliculitis, mainly in two settings: patients with acne who are receiving antibiotic therapy in whom gram-negative pathogens are selected out, and individuals exposed to hot tubs and swimming pools contaminated with Pseudomonas aeruginosa. Both types are uncommon. Pseudofolliculitis barbae is a disorder of the neck and jaw of men whose beard hairs are sharply curved. This configuration causes the hairs to re-enter the skin, where they induce an inflammatory reaction, resulting in papules and pustules. The ingrowing hairs can often be visualized. Keratosis pilaris is a common follicular disorder that presents as tiny, rough, scaling, and follicular papules, no pustules, on the backs of the upper arms, buttocks, thighs, and facial cheeks. Rarely, fungal infections can result in follicular pustules, referred to as Majacchi granuloma. These are usually associated with an annular, scaling plaque, which can be hard to detect, and therefore can be distinguished from the individual pustules of bacterial folliculitis. Differential diagnosis of folliculitis. Acne. Gram-negative folliculitis. Pseudofolliculitis barbae. Keratosis pilaris. Fungal infection. Hot tub folliculitis, originally pustules that became hemorrhagic centrally with characteristic red flare, often appear under the area of bathing suit occlusion. Pseudofolliculitis barbae. Ingrowing hairs visualized under erythematous papules and pustules. Majacchi granuloma. Red papules and pustules in periorbital distribution. Note fine scale and hint on annular arrangement of papules. Laboratory and biopsy. In staphylococcal folliculitis, gram staining of the pus reveals gram-positive cocci, and bacterial culture confirms the diagnosis. A biopsy is not necessary but, if done, would reveal a collection of neutrophils in the superficial portion of the hair follicle. It is important to send a culture and sensitivity test to check for methicillin-resistant S. aureus, MSA, a not uncommon hospital and community problem. Folliculitis. Epidermis. Subcorneal pustule at the opening of a hair follicle. Dermis, inflammation in the upper dermis. Therapy. Most cases of staphylococcal folliculitis are mild and can be managed with an antiseptic cleanser such as povidone-iodine, betadine, chlorhexidine, Hibiclens, or benzoyl peroxide used daily or every other day for at least several weeks. Antibiotic ointments may be used for localized disease, bacitracin or mupirocin 2%. For more extensive involvement, a 10-day course of a systemic antibiotic such as dicloxacillin, 250 mg 4 times daily, is suggested in addition to the cleansers. If a bacterial culture reveals MSA, then therapy should be directed by antibiotic sensitivities. We use doxycycline or trimethoprim, sulfamethoxazole most frequently for Malassezia. Therapy for folliculitis. Initial. Topical. Antiseptic cleansers. Betadine. Hibiclens. Benzoyl peroxide. Topical antibiotics. Mupirocin. Bacitracin. Oral. Dicloxacillin 250 mg QID. Alternative. Doxycycline or minocycline, Malassezia. Trimethoprim, sulfamethoxazole, Malassezia. Mupirocin tenaris for chronic carriers. Course and complications. Response to therapy is usually good, but recurrences are common. Such patients may be carriers of S. aureus, and more prolonged use of antiseptic cleansers is recommended. In addition, we often ask these patients to apply an antibiotic ointment, example, mupirocin, twice daily in their nares, because this is a common site for S. aureus. Other sites of colonization include the axilla and groin. Complications are uncommon and local. Occasionally, the follicular infection can extend more deeply, resulting in a furuncle that requires incision and drainage. Pathogenesis. In folliculitis, the bacteria gain entry into the skin through the follicular orifice and establish low-grade infection within the epidermis surrounding the follicular canal. Patients who carry S. aureus on their skin are more susceptible to this disorder. Remember that patients with atopic dermatitis are prone to bacterial infections due to lower levels of innate peptides in the epidermis that have antimicrobial properties. Occlusion and maceration are sometimes also predisposing factors.
Clinical case. A 24-year-old man presents with a 3-week history of multiple pruritic and mildly tender papules and pustules on the beard area and anterior neck. He reports that the lesions worsen 1 to 2 days after shaving. He recently started a new job requiring daily close shaving. Physical examination reveals erythematous follicular papules and pustules with several curved hairs re-entering the skin. No comedones are observed. The remainder of the skin examination is normal. What is the most likely diagnosis? A. Acne vulgaris. B. Gram-negative folliculitis. C. Pseudofolliculitis barbae. D. Keratosis pilaris. E. Folliculitis. Correct answer, C. Pseudofolliculitis barbae. Explanation. The patient has classic features of pseudofolliculitis barbae, follicular papules and pustules occurring in the beard area after shaving, with visible ingrown hairs and absence of comedones. This condition is caused by curved hairs penetrating the epidermis and inducing a foreign body inflammatory reaction. Acne vulgaris typically presents with comedones, papules, pustules, and sometimes nodules on the face, chest, and back. Gram-negative folliculitis often occurs in patients receiving prolonged antibiotic therapy for acne and usually affects the perioral or nasal region. Keratosis pilaris presents with rough keratotic follicular papules, usually on the upper arms and thighs, without pustules. Folliculitis is a broader term and may present similarly, but the shaving-related ingrown hairs specifically support pseudofolliculitis barbae.